So first we wanted to do a introductions of the team. So I am Kevin Ruane. I lead our analytic advisory practice. So I lead a team of consultants who work with our clients day to day on healthcare challenges, applying our analytics and methodologies to solve those issues. I have three of the consultants on my team, and I'll let them introduce themselves. Catherine?
Hi there, I'm Catherine Shanahan. I'm our Senior Pharmacy Analytic Advisor. My background's in pharmacology, toxicology, and research pharmacy and drug development. But for the past 10 years, I've been working with payers in the healthcare space to better manage specialty medications and their various pharmacy plans.
Great, Leah.
Thanks. Hi, my name is Leah Kamen. I'm an analytic advisor on Kevin's team. I've been with Merative for the past 12 years. I've mainly worked with large employers and payers to use their data to uncover insights to help manage population health of large commercial populations. My background is in public health. I have, prior to Merative, also been involved with some clinical research and some quality research with the health system. So happy to be here today.
Thank you. Brian?
Hi, Brian Briegel. Thanks, Kevin. Happy to be here as well. I've been with the company for a bit over 20 years now, and really for the past 15 years, I have been specifically focused on federal regulations that impact health insurance issuers and employer group health plans. So I really focus on those federal regulations that are either required for compliance or voluntary programs. Thank you.
Great, appreciate it. Adam, do you want to advance the next slide? So I just want to kick off just to give a little background. And again, thank you for joining this webinar, right? That we're going to be covering the 2023 payer trends. So we have a panel of thought leaders and experts here who are working day to day with our clients and hearing what our clients have to say. And we're also going to be sharing some of the things that we see in the data, right? So we are living in really unique and dynamic times, and no surprise to anyone on this call, I'm sure, right? We have inflation, we have the ongoing impact of the pandemic, the great resignation, the rise of telehealth, provider consolidations, pharmacy breakthroughs, legislative changes, right? There's a lot going on. So as Adam mentioned, we do have a poll. We want to make sure that we are creating the right content, not only hearing what we're hearing directly from our clients, but as we create new webinars, blogs, and thought leadership in the industry, we want to hear what's most important to you. So if you could take a few minutes and complete that survey, it would be greatly appreciated. We will publish the results in a future thought leadership blog that we have. Before I hand it over to the team, I did just want to just give a little background on Merative, and I know we have actually many clients on the call. The Merative name is new, about 7 months old. We were formerly IBM Watson Health. Some may know us as Truven, but we were acquired by Francisco Partners last summer. So exciting times for us for sure, but we're bringing forth the 40-year plus of expertise and methodologies and data assets under this new name. So new name, exciting time, but same team, same data assets, and best-in-class methodologies that we have. So to give you a little background on our customer base, we have over 4,500 customers across the healthcare ecosystem, 40% of Fortune 100 employers. We have 7 out of the top 10 payers, 70 plus state, local, and federal government agencies. And this is key as we are working with all these different clients across the ecosystem. This is funneling into our products and methodologies, right? We're consulting with employers and doing work with them and hearing what they want to hear from their health plans. The health plans want to be best in class and push out the account group reporting so we can funnel that knowledge in there. So it's really key that we're working across the ecosystem with all these different clients, really funneling our innovation, our products, and our methodologies. I did want to also touch on our data assets. MarketScan is key to our portfolio as well. And those who are familiar with our tools and our methodologies are going to be very familiar with MarketScan. So we have over 273 million lives in the de-identified data set. And this can be used, we are embedding this in our tools. So we have great benchmark data available for our clients who are licensing our products. So as we're talking about affordability today, right, I can see how I'm trending over time. I can see how I'm doing from last year, this year, I may be doing better, worse. But what how do I compare to the US? What's happening in the US, right? What's happening in my state? What's happening in my local MSA? I'm in a different industry. I'm in retail versus healthcare versus technology. That's all going to change things, right? I want to create a matched cohort in order to do a deeper dive analysis. So that's key to our solutions, and we create our predictive models and methodologies off that very robust data set. So our thought leaders today will be going through some of the insights that they've actually pulled from MarketScan. So I did just want to touch on that. Lastly, before I do hand it over to the team, I want to just talk a bit about how we work with clients. It does vary. And again, I know we have many clients on the phone today, but we have a full end-to-end solution called Health Insights, where we are doing the data acquisition, the data aggregation, the data cleansing, applying advanced predictive models and methodologies, benchmarks, creating executive dashboards. And what we're giving to the end user, whether they're a public sector client, health plan, employer, they have a very robust tool that has predefined content, extensive predefined content, as well as the ability to create their own. So they're a very robust analytic tool set out there for our clients. And again, that's called Health Insights. We also do a lot of consulting, and you're meeting three of the different thought leaders on my team. We work day to day with clients on their business problems. We have a full consulting staff here. Really want to be that strategic and consultative partner as we're partnering, and really where the client is at in their own experience, right? What does their staff look like? Where is the gap, right? Do we need someone like Brian, who's heavily involved in legislative and compliance? Catherine on pharmacy. We have a full consulting team. And then some clients also just want to license our methodologies and our data assets, and that's fine as well. They don't need the end-to-end solution, but they're not going to build an episode group, or they really need a robust clinical episode group, or they need access to benchmark data. We offer that a la carte, and we work with clients in that way. So I did just want to give you a quick overview of Merative, again, bringing the best forward through the years and how we work with clients today. And you'll see that firsthand as the team walks through some of these examples and insights that they're pulling out of the data. So with that, I'm going to turn it over to Catherine to dive into affordability. I appreciate everyone joining.
Great. Thanks, Kevin. Actually, before I jump in, just a quick housekeeping item. For the poll, I know it gets a little bit squished in that Q&A box. If you want to scroll down the box itself, you can scroll and see more options, or you can also move the Q&A box kind of out of the screen, kind of pop it out, and that will allow you to see more of the options that are kind of further down in the list. But so with that, I'm going to jump into the first slide. As I'm sure most of you are experiencing, the cost of care has risen significantly over the last few years. Allowed PMPY has grown 17% since 2018 and now sits at an estimated 7,207 in early MarketScan 2022. The largest cost drivers that we're seeing are prescription drugs and facility charges. Prescription drugs are up almost 10% year over year, and facility charges, both inpatient and outpatient, are up 13%. They now make up over half of all medical spend. So we'll talk a bit about this more on the next slide. So healthcare is becoming less affordable for both plans and members. 4 of the leading trends that we're seeing around healthcare affordability and how payers are trying to manage that include inflation and rising costs of care, the network consolidation that we're seeing and value-based purchasing agreements, high deductible health plans and consumer financial wellness, and then lastly, of course, specialty medications and pharmacy costs. So we'll dive into each of these topics at a 1,000-foot level today, but there will be, of course, more. We'll dive in deeper throughout 2023. So to start off with inflation and the rising cost of care, one of the biggest questions that we're hearing around the healthcare industry is how and when will inflation hit? So far, healthcare has been largely shielded from inflation. A study by the Kaiser Family Foundation found that while in the total economy, total goods and services grew almost 8% through October 2022, medical spend only grew 5%. But Given the landscape that we're seeing within healthcare, we're expecting this to change. So due to workforce shortages, the cost of clinical labor, so doctors, nurses, bedside care, et cetera, has risen significantly. This, in addition to the rising cost of medical equipment and drugs, is causing most hospital systems to lose money under their current contracts. We expect hospital systems to try and pass on this rising cost of care to health plans during the next contract negotiations. A survey of healthcare leaders by McKinsey found that most plans are expecting a decrease in margins between 25 and 75%, which could completely wipe out earnings and budgets. It will become increasingly more important to understand the quality, efficacy, and value of your provider networks. At Merative, we've worked with many health plans and employers to evaluate provider profiles, assess network quality, and working directly with your provider groups to deploy those best practices and cost-saving solutions. So next, the next section on network consolidation and value-based contracting. The rising cost of providers is also leading towards consolidation across the healthcare ecosystem. We're seeing independent provider offices are being bought up by larger hospital systems. Regional hospital networks are expanding into new territories. And then larger healthcare companies are expanding into ancillary services, so like CVS and their Minute Clinics or Teladoc and Livongo. This consolidation is helping those hospitals and companies increase their market power as they adjust to these rising costs. But it can also be beneficial to the payer through improved care. So in order to demonstrate the value to payers, health systems and plans are focused on improving clinical quality, care coordination, and then outcomes. So given that health systems are focused on improving cost and quality of care, most payers have some sort of value-based care arrangement, either bundled payments for specific services or COE networks for specific conditions, or ACOs or employer-provider partnerships, just to name a few. And value-based care arrangements will become even more critical in the coming years as costs continue to rise and margins become thin or even thinner than they currently are. At Merative, we frequently work with both health plans and employers to set these kinds of performance guarantees and KPIs with both provider groups, health systems, and even various point solutions. These evaluations can be as simple as identifying strengths and weaknesses within the current system or program, or as detailed as like matched cohorting using our MarketScan database. Meritive's integration across the healthcare ecosystem also sets us up uniquely to leverage tools and methodologies from across the industry, such as comparing a payer's claims experience with their utilization of our top 100 hospitals list. This type of innovative reporting is important to understand how your unique population interacts with the larger healthcare system, and that will be really critical for evaluating in the coming years. The next section on high deductible health plans and consumer financial wellness. All of this rising costs of healthcare ultimately impacts the member. For most payers, high deductible health plans have really become a cornerstone of their benefits offerings in the effort to help keep costs manageable. However, these plan types may be leaving higher risk members vulnerable and could be dissuading preventive care if members are unable to afford treatment. We're seeing a growing trend of payers trying to fill this gap thoughtfully, identifying high-value services and treatments, and lowering financial barriers for members for these types. As an example of this, we're seeing a growing number of payers expanding the preventive drug list beyond ACA regulations, such as including certain high-value diabetic medications. Although these payers expect costs to increase initially as patients become more compliant with treatment, the hope is that these increases will be offset with downstream improvements in outcomes. At Merative, we've helped many payers evaluate this type of financial wellness of their population and identify opportunities to improve care outcomes through incentivizing and making high-value care more accessible. Finally, the final section on specialty medications and pharmacy costs. One of the largest challenges of healthcare affordability has been specialty medications, which has grown 45% PMPY since 2018. With the emergence of immunotherapies and gene therapy drug classes, oncology is really one of the largest drivers of the spend increase. We've seen oncology treatments largely shift from older chemotherapies with their pretty heinous side effects to newer classes that are both more effective and less harsh on the patient. Many of these new classes, from oncology treatments to hemophilia, even the new weight loss medications, offer life-changing outcomes for patients. Because of this, many payers are not focused so much on whether or not they will cover these new medications, but rather how. At Merative, we work with employers and health plans on how to integrate these new medications into their benefits. What clinical criteria should a patient have? Who may have the clinical history to warrant this new medication? What outcomes should we measure? And how will the adoption of these medications impact budgets going forward? So next, we'll dive into some of the top trends and management strategies to reduce the impact of drug costs on healthcare affordability. Starting off with biosimilars, one of the largest opportunities that we're seeing to improve affordability is through biosimilar management. To date, 40 biosimilars have been approved by the FDA. Many are for cancer treatment, including like Herceptin and Neulasta. Others are for inflammatory conditions, such as the biosimilars for Remicade. And at the end of this month, the first biosimilar for Humira will come to market. Although on average, only about 15 to 30% less expensive than the brand counterpart, biosimilars are the closest to generic options that most specialty medications will have. But make no mistake, these biosimilars are not generic drugs. They will be managed through a preferred or non-preferred tiers, with rebates playing a factor, especially, of course, under the pharmacy benefit. And benefit coordination is key. Biosimilars and their brand counterparts are billed through both medical and pharmacy benefits. In this past year, we've seen many health plans work with their provider networks to improve the utilization of biosimilars where appropriate. PBMs, on the other hand, are in a unique situation because of rebates. It's unknown whether the manufacturers of the brand counterparts will offset this kind of claim difference with additional rebates to make up that 15 to 30% difference. Worked with many employers and health plans to evaluate current usage of biosimilars and then identify those kind of future opportunities. Next, we have our pharmacogenetics. So as I mentioned on the last slide, gene therapies are one of the largest and most expensive drug classes in the pipeline. Last month, we saw Hemgenix hit the market, the first of its kind, and I'm putting this in quotes, but cure, so to speak, for high-risk patients for hemophilia B. We expect these types of breakthrough treatments to continue hitting the market, including many for oncology, hemophilia, HIV, and type 1 diabetes in 2023. We've talked a bit about how we've worked with payers to understand clinical coverage and future impacts of these new medications. However, I wanted to briefly mention a gap that we've identified. So for many of these medications, gene testing is required to confirm whether the medication will work or not. But unfortunately, these test results are not included in claims data. To further complicate reporting, ICD-10 has historically not differentiated these conditions by genetic factors, meaning two patients could have the same oncology diagnosis with drastically different treatment options. Payers all agree that these life-changing treatments must be available for patients who need them. However, many are struggling to incorporate the high costs into budgets. As value-based care arrangements grow, especially those that evaluate provider networks on prescribing quality, it will become critical to understand and increase transparency into biomarker testing and genetic markers. And that really bridges me really well into this last section on prescribing quality. As I mentioned, we're beginning to see payers increasingly look to their health plans and provider networks to demonstrate high-value prescribing, making sure the right patient is getting the right drug at the right time. And high-value prescribing doesn't always mean the cheapest drug either, but rather those with lower side effects, low barriers to maintain adherence, and then, of course, highly effective outcomes. Health plans employers are also finding significant savings opportunity to offset the high cost of these new and expensive therapies by looking at alternative purchasing models, especially for generic medications. Multi-source generic medications make up about 15% of annual pharmacy spend and offer price management opportunities that just are not available for branded medications. Merative has worked with some payers to improve transparency and negotiations with PBMs around MAC, or maximum allowable costs, pricing tables that narrow down the pricing range of a generic medication. Other payers we've worked with have had some success in lowering contract prices through partnerships with third-party distributors like Cost Plus, that's new this fall. With each of these, the goal is to improve affordability for members while simultaneously maintaining or even improving the quality of care and outcomes. So as we see the drug costs continue to rise, driven by these, of course, new blockbuster therapies, it will become imperative for payers to implement cross-management strategies where they can. From biosimilars to measuring high-value prescribing, to alternative purchasing models and price transparency, we've begun to see payers lay the groundwork to slow this rising cost of drugs and help make treatment more affordable. So up next, I'll have Leah walk us through the trends related to healthcare access.
Thank you, Catherine. All right, hi everybody. I'm going to talk some of the trends that we're seeing in healthcare access. Healthcare access has long been a focus of healthcare service improvement efforts, and today we're going to go through 4 areas related to healthcare access, including some special challenges in the current environment and some promising innovations. The first we want to talk about is workforce strategies. As Catherine discussed, staffing shortages are driving higher labor costs, but they're also affecting access. Driven by the pandemic, there has been a decrease in the clinical workforce, and this decrease will be felt for many years. It is projected that the clinical workforce of nurses will be 20% below what is needed and 10% for physicians. Because of the pandemic's impact on healthcare service use, providers have been experiencing increased pent-up demand and higher severity cases. And as a result, patients are facing long wait times, and those wait times can vary widely by geography, provider specialty, and clinical condition. Youth mental health is a particular concern. Sometimes youth mental health services will take as long as 1 year of wait time. And there's evidence that urgent care and admissions are rising for youth under 18 as it relates to mental health crises. It's also estimated that 1 in 5 youths will have an episode of major depression before the age of 25. Merative has helped employers understand the impact of ongoing programs and policies that they have put in place to address youth and their adult mental health risks. Necessity being the mother of invention, this may be the time to truly re-envision the healthcare delivery process. Maximize efficiencies through new operational technologies, and have clinicians work at the top of their license, especially a way to have limited supply meet this growing demand. For example, cancer treatments, as Catherine talked about, is now the #1 driver of costs, beating out musculoskeletal for the first time. This being said, it's a top priority for many of our clients. Driven also by a delay in screenings and long wait times to catch up on those screenings, we're seeing payers exploring unique benefits or innovative treatments like multi-cancer early detection technologies, or MCED. And these technologies use blood, breath, urine, saliva, or stool, and the clinicians can rapidly screen these samples for multiple cancer types at once. While this technology is new, it's not yet approved, employers and health insurers are preparing to cover these screening tests, and Merative is working with our clients to help them to understand what that future might look like. The next section as it relates to access is provider capacity and closure. Catherine also talked about this as it relates to costs, but it is impacting access as well. Trends in provider consolidation are driven by financial stress and private equity acquisitions. We're seeing vertical integration between providers and payers and horizontal integration across providers. And this trend is active and it will likely increase. This in turn will lead to decreased access in specific geographic regions and other services through provider closures. Many of you have probably heard about closures of rural hospitals. I think there's been 100 plus closures of rural hospitals since 2018. So this is a trend that we expect to continue and will have great impacts on access. When a rural hospital closes, patients' access to cardiac treatments, patients need to drive an additional 4 or 5 hours or so for cardiac treatments, and sometimes almost triple that for mental health treatments. Short of closure, in response to these margin pressures, hospitals may get out of low margin businesses and scrutinize their payer mix. 50% of hospitals lost money in the third quarter of 2022, and some dramatically. And that financial stress is expected to continue for 2 to 3 years. So providers will need to have resources to weather that storm, but some will be submerged. As a result, from a payer perspective, there is a need to monitor network access, adequacy, and access at the local level, and to address some of these access issues through innovative benefit designs like digital health and medical tourism. We commonly hear about maternity and mental health deserts, and these are a problem especially in rural areas with high social needs. These areas have trouble attracting and retaining providers. Merative has recently analyzed mental health provider deserts, and the analysis showed that the lack of mental health providers can lead to worse outcomes that go beyond mental health care. The next topic as it relates to access is virtual health. On a more hopeful note, the pandemic has accelerated the use of virtual and digital healthcare. Both providers and consumers have accepted this form of healthcare visitation. There's evidence that virtual healthcare can efficiently deal with geographic and other inequities in access. The saying that all healthcare is local may no longer be true. Telehealth is the most prominent technology, but there'll be some others as well, such as remote patient monitoring or hospital in the home, and there is a path of adoption by innovators. However, what the impact is on quality, outcomes, and cost is yet to be known. While it's emerging, however, there is a robust research evidence base does not yet exist. Merative regularly works with our clients to understand the adoption of virtual care services. These analyses focus not only on the trends of use, but also on indicators of quality. For example, are virtual care services replacing in-person care, or are they adding another visit? And we've run some data from MarketScan to try to start to answer this question. While this technology is promising to deal with access gaps, the telehealth sector is also consolidating, and there have been some fraud cases brought by CMS. So while it is a time of promise, it's also a time of flux for digital health. Lastly, I want to talk about healthcare consumerism. Given the uniquely challenging environment that Catherine and I have been describing, consumers and employers really need to engage to make the system work for them. Healthcare consumerism means providing information, financial incentives, and decision-making tools to consumers to allow them to make educated healthcare purchasing decisions. There is a growing segment of the population that are willing and capable of engaging in their own healthcare in non-traditional ways. Prompted by the pandemic, consumer-focused digital health apps and software have been part of opening that door. For example, Calm, the meditation app, was recently valued at close to $4 billion. Consumerism includes benefit and price transparency. For example, the health plan price transparency rule, which became effective on January 1st, 2023, opens up a range of possibilities which we are actively exploring. Brian will be talking about more of this shortly. Merative has a long history of offering transparency tools to consumers, including benefit selection tools. Merative regularly helps our clients to measure the effectiveness of consumer-oriented programs and tools that aim to improve consumer education, increase consumer engagement, and improve condition management. While this is not necessarily a trend, it is an important time to start measuring the impacts of these programs, especially as a way to fill access issues in light of the pandemic and all of the disruption that the pandemic has brought to the healthcare system. However, given high interest rates, venture capital has decreased dramatically. A digital health sector shakeout, including point solution vendors, is underway. So this is just really a high-level summary of what types of access issues we're hearing from our clients and we're hearing in the literature. Throughout the year, we'll dive more into these issues through our blogs, our newsletters, and our webinars and our roundtables, which you'll hear more about as we go on. But I did want to take you a little bit deeper into what we see from MarketScan as it relates to telehealth. So next slide, please. We are an analytics company, so we need to bring some data. So in 2023, we were talking about this now may be a pivotal year for telehealth. As we talked about, there's shakeups happening in point solution vendors, there's fraud potentially happening, but there's also a ton of interest in telehealth, and that interest is not waning. So as a way to improve access and reduce costs, people are turning to telehealth. But they're looking to us to answer questions about some of the skepticism that they have as well. Telehealth is regulated somewhat by the federal government. So with the December federal budget bill, this extended CMS flexibilities until December 31st, 2024. And importantly, it decoupled it from the end of the PHE. So there's a 2-year window now for the industry to gain the right footing. Back to those concerns. So some of the concerns that we see and are asked about is whether or not telehealth is really just being cost additive. Also, it's supposed to build bridge some of those inequities that we hear about, but there's also some concern about inequities in accessing virtual care, such as those that don't have regular access to broadband or low digital literacy. 3, there's also a question about the impact on clinical quality and outcomes. We've heard some anecdotal stories about patients who call into telehealth with an upper respiratory infection and may get antibiotics as a knee-jerk response to those symptoms. And we know that antibiotics will not help with viruses, which are a common cause of upper respiratory infections. There's also concern about fragmenting further an already fragmented system. We know that patients will oftentimes see multiple providers for their multitude of conditions, and those providers don't necessarily talk to each other. Telehealth may just be another stop that people have that does not get integrated into their total care. So we ran some data from our MarketScan team to understand some of these trends. and we looked at both in-person and telehealth visits for primary care and behavioral health care. This slide right now is looking at behavioral health. So the use of behavioral health jumped substantially in 2020. Since then, it has dropped somewhat, but it still remains very high. Since many behavioral health treatments do not require procedures, testing, or touch, behavioral health visits are an optimal candidate for telehealth. And not surprisingly then, because of that, telehealth visits make up almost 70% of behavioral health visits. And this proportion has remained fairly high the further that we get out from the onset of the pandemic. Since this proportion of behavioral health visits is not dropping, this may indicate that one barrier to receiving behavioral health treatments prior to the pandemic was access, and telehealth has come in to solve this. For more information on telehealth use in behavioral health services, Merative recently published an article in Health Affairs using MarketScan data. The next slide, we're looking at primary care utilization trends. High level, primary care utilization trends remained high throughout the pandemic. While the proportion of primary care visits using telehealth does not get to the same level as behavioral health, we do see an interesting trend that approximately a quarter of all primary care visits with people are using both telehealth and in-person services. We call those hybrid. This could mean that people are using multiple primary care services throughout the year, and some of them they're doing in person and some of them they're doing virtually. But this could also indicate that for a portion of patients that prefer telehealth, and so they're going to telehealth first, telehealth may just be an additive visit. Merative regularly supports our clients to understand how telehealth fits in or has disrupted the normal workflow of services and the cost impact of these changes. For example, we can leverage our unique capabilities in our reporting tool to quantify patterns of telehealth visits and in-person visits for various conditions. And that's all I wanted to share today. I'm going to now turn it over to Brian to talk about some of the regulatory trends that we're seeing. So thank you for your time, and we look forward to answering your questions.
Thanks, Leah. So we'd like to share, as Leah mentioned, a bit of a regulatory update that do play along with these trends that we're seeing in terms of affordability and that are very much on the radar of CMS and the federal government and actions they're taking at that federal level to put some downward pressure on prices, improve transparency in cost and price, and really attempt to drive consumerism into the healthcare market. If we can go to the next slide, please. If we can just bring them all in, please. Thank you. Okay, so I want to just first level set to go through a variety of actions, both statute and regulatory requirements that are impacting payers. There's quite a few of them here. Talk through those. Talk about some overlapping requirements, all designed to help flip the paradigm of having consumers of healthcare, your members, receive post-service explanation of benefits after the care has been rendered, and to spin that around and bring that information that exists today on the explanation of benefits and make it pre-service to help members shop, perhaps make better purchasing decisions, and again, drive that consumerism into the market, all based on taking the information post-service and bringing it in front of service, making it shoppable, and helping make some perhaps better choices based on price and quality as well. After we go through these, I'll talk about the overlap and some of the tools and requirements and how they interplay. And really, with these tools, once they're rolled out, this is great framework being set and being required of payers with the aspirations to drive in that consumerism and transparency, but how to put that to work, how to activate your members to be in this new world of pre-service information, to know where the information's at, use it, and help put some savings back to the plan and back to the members in their pocket as well. So to go through these, we'll talk a little bit first about the Consolidated Appropriations Act that was signed into law. There are two sections that impact payers, specifically the No Surprises Act. And the first thing the No Surprises Act does in terms of affordability, it puts really strong consumer protections against balanced billing. for emergency services that are rendered out of network, as well as for services rendered at an in-network facility, but unbeknownst to your member by a provider working in the facility that is out of network. So the balance billing in those cases no longer allowed, prohibited. There are some exceptions with the in-network facility and that out-of-network provider in non-emergency cases and get waivers signed, but by and large, there is prohibition against these surprise bills and balance billing. So really important consumer protections there. And that runs into air ambulance reporting. As you may know, be aware that air ambulance services are often historically a significant cost impact, significant driver of surprise bills to members who often have, financial shock, if not dire financial straits due to balance billing from air ambulance providers. With the No Surprises Act, the balance billing cannot happen anymore. And in working with some of our health plan customers and helping to create and build their required machine-readable files, in discussing this with them, they have already seen air ambulance providers, some of them come into network because the balance billing is no longer an option for them. So air ambulance reporting is a payer requirement, a provider requirement as well. We're going to see in the March timeframe, probably pushed out to June based on feedback from stakeholders saying it's a 2-year requirement to report in both payer and provider side to understand network participation of those air ambulance providers and put out some public reports on how this No Surprises Act may have shifted network participation on that front. And then there's the good faith estimate. That's a provider requirement to, again, on the request of your member or on a scheduled appointment to provide to them in advance the services that are going to be rendered and the intended charges from the provider. That is going to feed into a forthcoming payer requirement, the advanced explanation of benefits. We don't have rulemaking for the payer requirement yet, the AEOB. We expect to see that here in the first quarter, a notice of proposed rule with comment period that will require the payer to take that good faith estimate from the provider, process it for the member, run their benefit information against it, and produce payer-specific data, member out-of-pocket cost share, how much the plan is going to pay, accumulation to annual deductible, and payer-specific information with benefits applied back to the member. Again, that's not required yet, but there is active rulemaking, proposed rule we expect to see in this first quarter. And there's also a requirement for payers to deliver a shopping tool for members to self-serve and shop in advance of care under the No Surprises Act. The second title that impacts payers in that Consolidated Appropriations Act is the Transparency, Title II Transparency. And significant, we call it there, is a no gags clause. This prohibits payers from entering into contracts that would disallow them to disclose provider-specific cost and quality information. So at Merative, we're encouraging all of our employer plan clients, all our payer clients to review your contracts as they come up for renewal, hold that up against the no gag clause and ensure any prohibitions on disclosures of provider level quality and price are removed from your contracts. Another significant component in the transparency title is the prescription drug data collection. This is a new requirement, as we mentioned prior about prescription drug trends, driving costs and rebates. The departments want to understand health insurance issuers, employer group health plans. What is your annual spend on drugs? What are those top cost drivers in prescription drug and your benefits? How do those compare year over year? How are rebates? What are the rebates, in fact, for those drugs, those top drugs? And how are those rebates impacting premiums charged to your members or not? Those are all components. There's additional information in these reports that are required, such as spend by medical category, premium and life year. But really the core focus is to understand what are these cost drivers with prescription drugs, how do rebates impact premiums. And we would encourage, we work with many of our employer clients and some of our health plan clients as well to create and deliver these reports into CMS. We would encourage you that CMS says on the PBM side, PBMs can aggregate and perhaps report the entire self-funded employer book of business in aggregate. And then that's fine, they can do that. But CMS also says, as an employer plan sponsor, self-funded, it's your responsibility to make sure the data is accurate and submitted timely. So we've worked with PBMs, plan sponsors, and encourage you, if you're not getting your individual reports on your drug spend and your top drivers, on your rebates, we encourage you to begin to ask for that from your PBMs. Some have been more cooperative than others, but the entire spirit of transparency and you understanding your cost, and in particular rebate impact to your costs, we think it's important you have that information. So moving over to transparency and coverage rule, we just mentioned transparency and coverage rule was actually finalized 6 weeks before the Consolidated Appropriations Act came into play. And so we've got in red font here, it also had a requirement for a shopping tool that went through notice of rulemaking, final rulemaking. A lot of important market feedback came into play for this final rule. And it really is the stronger, more specific, the requirement for the shopping tool in the No Surprises Act was literally 2 sentences saying you have to have this tool. The departments have said, we're going to harmonize this. You comply with the shopping tool in the transparency and coverage rule. We'll consider you to be compliant with the Consolidated Appropriations Act as well. So that's really the focus on the shopping tool front. And then when we think about the overlapping requirements and tools, we have the member-facing shopping tool, and then we have this forthcoming advanced explanation of benefits. And again, each one of those, the tool and the AEOB, is designed to get that explanation of benefit that you get last year post-service, and to bring it in front of the consumer, your members, before they have service or when they are shopping for price. And if we go to the next slide, please. And we think about this, these different tools and method to get that information to your members up front. There's the member self-service shopping tool. And then we think about the advanced explanation of benefit again, right around the corner. We should see some rulemaking on this, proposed rulemaking with comment period to say, here's a method to shop through the provider. Today, coming online, just this month, was the requirement to have 500 items and services defined by CMS across all payers as a floor in that member-facing shopping tool with specific functionality as well. And that's to give the members experience, no matter who your employer is, who your payer is, as you move from tool to tool, kind of a level set of what you would experience as a consumer shopping for services. They want it to be uniform, and that's the reason for the federal action here. The aperture opens then in January of 2024 from 500 very shoppable services into all items and services covered under your plan. That could be tens of thousands of items and services in that shopping tool. Then we think about the shopping through the provider, which again lets a member say, instead of the shopping tool, I'm going to call the provider, schedule an appointment, make a request. They'll package the services they're going to render to me, what they intend to charge, and they will move that information to the payer, to the insurance plan. And the payer then will package together the advanced explanation of benefits, once again, wrapping around payer information about the member's benefit accumulation to date, maximum out of pocket, if the provider's in network or out of network, and other disclaimers, similar information that you get from a member-facing shopping tool. And the department said, hey, we acknowledge and realize there is some overlap here, and they even in some ways tip to some convergence. Do they merge these two tools at some point in time and have one front? Imagine trying to reconcile, hey, I shop through a tool, I shop through AOB, I got different information, and they're going to call you and have you explain why. That could be a real consumer nightmare, and a nightmare in terms of cost for you as a payer as well. But they issued a request for information on this forthcoming advanced explanation of benefits to say just that. We think there's some convergence here. Can we leverage the shopping tool to affect the AEOB process? The reason that the AEOB process isn't required today, there aren't standards that exist that allow providers to transmit that data with specified standards to payers and to interchange the information. That has to be laid out. And that was one of the other questions in the RFI. What standards should be used? Should we adopt FHIR? Are there provider burden things we should think about in terms of rural payers, rural facilities, that this would adversely impact them, but they have to comply with specified healthcare standards to exchange this data? So really, what's the cost in seeking to hear from the market, provider and payer side, what's the cost and impact of trying to bring affordability into the market? How much cost, and might there be some interference with care, which would be inadvertent and not intended? So And there was some questions and comments as we commented back in the Merative. We have keen interest. It was mentioned we have a benefits tool. We had a shopping tool, consumer-facing shopping tool in the market now for at least 15 years. We pivoted to comply as required. None of these regulations continued to develop that. And we wanted to weigh in and say, in working with our health plan clients and payer clients, we don't see utility in expanding beyond 500 shoppable services into tens of thousands of services. We think that is a large lift, degrades the consumer experience, is going to confuse and probably lose members, a lot of work with no value. So our commentary, and in reading through comment from other payers like AHIP, for example, the Blues Association, along with us, also said, hey, we think you cap the shopping tool member-facing, keep it the very shoppable service as it is today, and take the requirement for all items and services covered by the plan and move that into the realm of the AEOB. The provider can package the information up, move it over to the payer, let the payer do this AEOB adjudication on that information, and then transmit that back to the member. We think that's a better way to go, better experience, and more practical, frankly, than to move tens of thousands of items and services that will probably never be utilized in a member-facing shopping tool. So with that, in reading the summary and feedback from the provider side as well, we think about the departments and what they need to do with this information they receive from the request to help them inform on this forthcoming rule. And we think they really have to think about provider burden. We talked about the scarcity of providers. If you read the feedback from mental health providers in particular saying, if you are going to require that we adopt new standards, there's a big push, a good push for interoperability based on FHIR. That's important for interoperability. But saying if you have to introduce this new process and new standards, you're going to put some small practitioners under. The cost is not bearable. The strain today is already significant where these good faith estimates have to be provided to uninsured or self-pay members. Providers have to do this today. And that's causing stress in the system, in the provider system, and strain on their resources. So also feedback saying, FHIR is great, we support FHIR fully, but there needs to be a stepwise and on-ramp to FHIR. If you're going to require this provider-payer interchange, use existing X12 HIPAA transaction sets, things that payers and providers handle today, and expand that before you cause a shift to FHIR. So just in summary, the departments really have to think about what's been fed back by way of this RFI as they roll out this proposed rulemaking. We're looking forward to seeing what comes out and what feedback they took under consideration. And maybe we'll comment in again, depending what comes out in this proposed rule. And then next slide, please. And the last we'd say with this, again, back to the paradigm shift, right? With all this infrastructure, these tools, the AEOBs, that getting this information from post-service out in front of your members before they make a decision to schedule an appointment or they want to shop and get price information to make consumer-driven decisions. You think about the awareness, the education of your members. Are they aware of the tools? Are they aware of the limitations and the value of each one? Where is it at? How are they incented to use, right? Changing the consumer, the member behavior, awareness, educating, and incenting use of these tools and methods really has to happen to bring any kind of cost sharing back to them, back to you as a plan, and ideally, right, to put downward pressure on prices in the healthcare market. So we leave these things for you to consider. All right, back to you, Kevin.
Hey, Kevin, I think you might be on mute.
You are correct. Thank you for that. I would have kept going. So as I mentioned at the beginning, there's a lot to unpack here, right, as the presenters just showed, not only from our topic perspective, but the depth and the level, the many layers for each topic that we can go into. So I thought they did a great job. I really appreciate everyone's update, as well as providing those MarketScan insights as part of that as well. Very valuable. We don't have a lot of time left, and I know there were a queue of audience questions. We will make sure they're responding. I saw that some of the responses were already going out as we were talking. We'll follow up on any of those specific questions as well. If we will likely not get the chance to answer them. We did have a few topics just for the panel. I'm just going to cover a couple just really quickly. And then again, if you could fill out that questionnaire, very beneficial. We want to make sure that we're on point for these topics and webinars and blogs, and they're meaningful, and it's the highest priority for you, right? And we expect that to pivot. We talked about this as a very dynamic and challenging time. We expect to be doing these surveys throughout the year to make sure we're on point. One question I did have for Catherine, when we're talking about affordability, you had done a roundtable with clients that was really well received last month on polychronics, right? Talk to the team what you're seeing. Population, high-cost claimants are often being driven by polychronics. People have multi-chronic conditions. Can you share a little bit on what you learned and heard and how you're working with clients?
Yeah, absolutely. So as you said, last month we hosted that roundtable. It was about 50 payers or so that joined us to discuss the management of polychronic patients. So polychronics meaning patients with like 2 or more chronic conditions. At that roundtable, University of Michigan spoke around their polypharmacy program. So in which patients that had complex care, so taking multiple different conditions. And as Leah had pointed out, usually those kinds of prescriptions come from multiple different specialists. So they had those that kind of polychronic prescribing, all of those different prescriptions from all those different providers reviewed by a single pharmacist to kind of look to see if there's any areas to improve the medications being prescribed. Was there any possibilities of combination medications that might work better? Were there any avenues to remove medications to improve care? And so they found quite a few examples where medications were removed, where medications were streamlined. And so we pulled payers during the roundtable and found that many of them were experiencing the same type of issue specific to metabolic disorders. So metabolic disorders including like obesity, diabetes, hypertension, dyslipidemia. And they were seeing that there was quite a bit of polypharmacy for patients that were polychronic with metabolic disorders, lots of different prescriptions that may overlap or may have opportunities to streamline. Only about 20% of the payers during that roundtable had a current benefit to manage this kind of polypharmacy, but over 75% were considering one going forward. So many are looking into this area of polypharmacy and polychronics to better understand if there's improvements that can be made to their prescriptions.
Great, I appreciate that.